Array and multiple sclerosis for this afternoon. Again, we have Debbie Backus beaming in and Madeline Sharko appearing to talk about those. Madeline Sharko is a Guillain-Barré survivor, highly intelligent, so she presents a nice story about it. And then if we have time today, we'll talk about myasthenia gravis, otherwise that'll get punted to next week. Next week, we'll talk about ALS, post-polio, West Nile, and AFM. Okay, so same PowerPoint, it's just going to be kind of a continuous run. So we're going to start with, so you want to consider the lesion briefly, because that tells you where and how the disease process might act or react. Okay, so just to keep in mind that consider where the lesion, if it's considered an upper motor neuron or a lower motor neuron. That's Liam. Okay, so when we talk about Guillain-Barré, there's a couple things that you need to know that separate this from MS. Okay, and so somebody's going to show up at the hospital or the doctor's office complaining about certain things. Now direct access, they very well may show up in front of you, and then you may have to determine, do you need to go, is this kind of a weakness thing, where is this, and is it something that PTs need to deal with, or is it an emergency medical situation? Guillain-Barré, typically if you do the history on the, and for folks, once they get diagnosed with Guillain-Barré, it's all about the history. And what they'll report is that they were exposed to some sort of virus that they didn't give much credence to 1 to 3 weeks prior. So they had a little flu, they had a little headache, they had a little whatever. They thought it was nothing, and then all of a sudden they woke up and it's kind of basically, the immune system is attacking its own myelin cells. Okay? So it's the body attacking itself. And in that, then, Guillain-Barré, you have an acute inflammatory demyelinating polyradicular neuropathy. So all of those big words that will score you lots of points on Words with Friends basically means that lots of nerves are losing their myelin suddenly. Okay? Versus MS, where it's not necessarily sudden, but they're also having myelin problems on their nerves. But these guys, it's acute. It's caused, the problem becomes in the Schwann cells, and the breakdown in the Schwann cells. It affects the nerve root and the peripheral nerves. Okay? So you might not see, and you shouldn't see a lot of spasticity in these cases, because we're talking about peripheral for the most part. We want to know, again, about the incidence of it and the predisposition, and we're going to talk about that a little bit, and whether it's actually a viral exposure or folks have been exposed to a toxins that destroy some of the metabolism. So you have to ask where folks live. Do they live near a copper factory? Do they live near, if you live down in, is anybody from the St. Louis area? Okay, so what part? Where do you live?
I live in Collinsville.
Oh, Collinsville, okay. So, and some days you wake up and you're like, holy God, the universe died today, right? Because Monsanto was putting out a lot of stuff, or the rubber factory, or the copper factory. They're all there, right along the Mississippi River, is putting out tons of toxins. And so that may be an impact of where folks are living. When we talk about Guillain-Barré, diagnosis, again, via history. Clinical presentation. So we're looking at folks and asking, what happened to you in the last month? Where have you been? What have you been doing? Travel anywhere exotic? Clinically, what is it looking like? Are you having pain? It might not be this. Are you having, a problem with your shoulder? It might not be this. Okay. Are you tripping and falling? Maybe. You're going to go to the ER and they're going to get a cerebrospinal fluid. They're going to get a spinal tap right away. They're going to try to look for antibodies in the cerebrospinal fluid. They're going to do an EMG right away. Try it again, pick up what's going on in that nerve-muscle relationship. And then they're going to look for cranial nerve involvement, particularly the facial nerve. Okay, we'll talk about as those things go on. Once the docs, this is oftentimes confused with West Nile virus. They're like, oh, you have West Nile, go on home. You've just been bitten by a little mosquito, renegade mosquito, go on home. So folks go home and they continue to get worse and worse and worse. So they come back. Once they're diagnosed with GBS, you immediately get put through the ER and you get them straight to the ICU. because what is expected to happen is not going to be good. Okay? You're going to continue to lose very quickly function. What happens is that you get into rapid respiratory paralysis. Okay, so what's the one way to keep you alive if your respiratory system decides to become paralyzed suddenly?
Intubated.
You gotta be intubated, you gotta be on a vent. Poll of hands, who has a vent at home? Not a lot of folks. So if you're at home and you suddenly can't breathe, there's not, they can do CPR and they can do mouth to mouth and all of that stuff, but it's much better when your body decides to quit that you're in the ICU than you are in your living room. Okay, and we'll talk about that a little bit. And then, interestingly, so today and next week is the game that all PTs play. If I had to choose a disease, what would it be? Okay. And down here, if you haven't played it yet, you'll be playing it soon. You might want to choose GBS. It's a good one because you actually recover. So you have this complete crash. Yeah. I'm telling you, at the end of the day, you let me know which one you're going to pick. Functional recovery varies. Could go all the way to being back independent to a little bit of residual weakness, but look at the time frame, up to 2 years. Okay, up to 2 years recovery. And so that means that people are involved in physical therapy for a really long time. So sudden onset, paralysis, go to the ICU, and then we'll see you in outpatient. Okay, for a long time. Management, so when we talk about management, then we talk about pharmacology. Okay, so a lot of what they start to do is intravenous immunoglobulin. Because they're trying to minimize the viral impact. So they're trying to boost your immune system. All right? They may do a plasma exchange. Basically, a lot of this is because they really don't know. So we're going to throw everything at you to try to clean your blood, clean your immune system, get rid of what this problem is that's causing you to demyelinate. You're going to get respiratory support if you need it. They usually don't trach and vent people until they need it, but typically folks with GBS do need that eventually. Madeline hopefully will tell the story about how she came to that. She was in the ICU. She's an attorney. That sends out the flags all over for hospital administrators when they admit an attorney. And so when they went to put her on, she was unconscious when they went to put her on a respirator. She had to consent to that. Okay. For you and I, it's not a hard decision. Because if you don't go on the ventilator, you're not going out the front door of the hospital, right? You'll get PTOT in speech. Why? Why? We have somebody who's demyelinating, completely developing this fast paralysis. What is PTOT in speech going to do?
Making sure you can maintain.
Maintain, good positioning, good skin. Because you know they're getting better. So whatever you can prevent from going awry early on makes your job a little bit better when they show up for some pretty intensive PT. Passive range of motion. Give the family something to do. Nothing like fine little, P&F stuff while you're sitting in the ICU to make your family member happy, right? And usually the first thing you tell them to do is go find the nearest store, Target, Walmart, whatever, to get a pair of high top shoes. Because these folks get significant foot drop. When they're laying in bed, they get significant foot drop. And so if you have the sheets and the blankets on top of your feet while you're laying in bed, right, that's just pressure pushing you down in a plantar flexion. So if you get somebody some high tops, little chunky Converse high tops, they don't have to wear those big, awful looking AFO with the sheepskin in the middle to make it look like you're sick. And this gives the family something to do. Go find a pair of shoes, make sure they're pretty, bedazzle them if you must, and put them on this person, your family member's feet, and that'll at least keep you with neutral range of motion. Okay? And then pain control. And so a lot of times if they're doing pharmacology pain control, or are they doing some mind pain control, where they're just trying to get folks to get a grip around their pain and what's causing the pain. Especially as they're losing movement. So in the pathology, this is kind of just a brief overview of sort of what happens, is you get some lymphocytes that infiltrate spaces. These cause a patchy demyelinization, but that myelin grows back. Okay, so that's the thing you need to know, is that there's recovery in GBS. Clinically, there's very specific clinical presentations that they go through. What we're looking for is symmetrical ascending weakness. Okay, starts in your toes and creeps its way up. So folks will report that they were they thought they had a flu, they weren't feeling great, but then they started to notice that going up and down the stairs, they have toe drag, or they trip over their foot. Okay, and then a day or so later, they couldn't even stand on their legs. Okay, so this isn't like I had foot drop for 3 months and then I realized, oh wow, I can't stand or I'm having trouble getting out of bed. This is hour to hour, day to day. So ascending weakness, that's important to remember. Tendon reflexes are diminished. So you can do your patellar tendons, your bicep tendons, and you're going to see a diminution of that. You want to look in the medical record to see where they're at, where they are. Okay, so that's going to tell you a little bit about how that muscle and the spinal cord is performing together. Part of it is this missing mile. Respiratory failure is always a problem. Autonomic nervous system is a problem. And then sensory symptoms. So they do have increased pain. They may have a hypersensitivity, okay, to things. So all they want on them is like a little sheet. They don't want, things hurt to touch. So when we're thinking about these, then how do we do this, Derek?
So in your notes on the bottom, it says lower extremities followed by UEs. By ascending weakness, do you mean just more proximal?
Just still going up, and then the lowers occur first, and then you get fingers to shoulder.
All right, because it says lower extremities followed by the upper extremities.
Yeah, I think it's the reverse. But we'll double check that. Mary, do you know off the top of your head? Upper extremities impacted before lowers, or lowers before upper? Yeah. I think it's more just ascending in particular.
It's more ascending. Sometimes somebody might present with upper extremity and then
He's saying to start your toes first, or do you get it to your extra muscle? Because it's typically for ascending.
So-
Fingertips to your
So don't be too worried be more worried about the ascending. You're going to get your extremities first and then your chest. Okay? So people aren't going to report to the ER that they are having trouble breathing. I mean, they eventually will, but they're going to say over the last couple of days I was having trouble walking and transferring and grabbing things. Okay. Paresthesia without loss of sensation. So again, they're having some movement stuff, but they're hypersensitive. Okay? Weirdly sensitive. So things hurt more than they should. So when you go to do your sharp dull test on these folks, you got to be mindful that it's going to be magnified for them. All right. So the course of paralysis and recovery varies individual to individual. That's the first question that folks are going to ask you. How long is this going to take? You're like, somewhere between now and 2 years. That's not recovering, people, okay? But it varies patient to patient. What you want to know is where this point of nadir hits, N-A-D-I-R. Okay, that is when you hit rock bottom. This is when the person has completely demyelinated as much as they're going to. And again, it's variable, patient to patient, but they've hit the worst stage that they're going to get, and then they start to recover. You start to see some improvement. So you have to wait for this nadir. They have to, and that's the docs will call this when they think that the person has completely lost the function that they're going to lose, and they're going to start to see things come back. Right? So that's important for us because after this point, that's when we can start to be more aggressive and more intensive. Until then, it's a bit of a waiting game, and you're doing just like folks over here said, you're just sort of maintaining and trying to keep people intact as much as possible. All right? Medical intervention, we talked a little bit about already, but you want to get you need superior acute support or folks are going to die. Then cardiac and respiration, and this whole medical team gets involved. So you have your pulmonologist, you have your cardiologist, you have your neurologist, and then your PM&R team as well. And most of the time they'll do a drug-based intervention, again, trying to mitigate your immune system that's failing. All right, so immunosuppressive agents, plasma exchange, we already talked about a little bit, the intravenous immunoglobulin, respiratory support, all of these things, again, are mindful. Here, PT is coming in because we're going to do transfers. We're going to get these folks rolling in bed mobility, and trying to get them up again. OT might be doing some splinting to prevent contractures of the fingers and the hands and the wrist. And speech may be doing some swallowing. Your evaluation should be very specific to what's going on with this person. So you specifically want to look at motor, okay? How are they moving? Now, the first time you meet them, their movements may simply be eye-opening. Okay, can they open their eyes and close their eyes? Okay, can they blink? How are they communicating? Are they doing the yes-no blink? Are they sort of eye-pointing? What's the communication? Folks do not lose cognitive impairment. They do not lose cognitive. So they're completely cognitively aware while their body is shutting down. Okay. We may do some respiratory, or we may be involved in helping for positioning as they're doing some respiratory and some swallowing. You want to know about, are folks choking on, are they at choke risk, or even on their saliva? How are they managing their own secretions? Let alone, are they on a little bit of fluid, ice chips? What's the protocol? You don't want to be the one that when somebody can't swallow and they're like, I need some water, I need something. And you're like, okay, here. And then they choke. That's a problem. Okay. We want to minimize their pain, obviously facilitate in recovery of the respiration and their swallowing, working with the team to do that. You want to minimize your pain, prevent contractures, pressure sores, and injury. These are folks that are highly motivated to get back to their lives typically. So they're going to push the envelope. Okay? So you want to make sure that they're not falling, tripping, busting a leg, busting an arm, because they decided they got out of bed at therapy, so they certainly could do that at 2 in the morning. Okay? So you have to be careful of that. And then we want to introduce a graduated active exercise program, minimizing eccentric contractions. Okay? So you want to just minimize, do some concentric work, isotonic work, but minimizing those eccentric contractions right at the beginning. All right? So lots of hold. Can you hold? Can you just generate a contraction here? Can you sit up and just stay sitting on the side of the bed? Okay? Can you simply do ankle plantar flexion and dorsiflexion easily? All right, does that make sense? But very little resistance to start. In fact, you might you follow kind of that nice PNF progression or the other progressions of passive range of motion to active assist to active to resisted. But don't come out starting day one with resisted activities. Okay? They're going to want to do more and more and more. So your job is to hold them back and keep them in a safe zone, in a safe range. Specific questions you want to ask when you're starting with the patient. Now, due diligence is, if you've seen this in the medical chart, then you might want to weave it into conversation, but don't lead off with, so tell me when your first symptoms, what they were like, and you read the whole story, because if you've read it once in the medical chart, they've told it about 10 times already. And so give them the nod that you know that you've read the medical record. So I saw that you thought it started about 3 weeks ago, and this is kind of what you reported. Is that still pretty accurate? If you remembered anything else that I need to be aware of? But if any information you can get, then they don't have to retell the story over and over again. Okay. Did they have a cold? Did they have a flu? What was going on ahead of time? If these questions haven't been asked yet, then feel free to ask them. You can add to the medical record. If you're in an outpatient setting, and you don't have access to those inpatient records, or you're in the rehab setting and you don't have access to the inpatient records, you want to ask these questions, including how many days was it until native? How long until you completely crashed? And when has it been 3 months since then, 6 months since then, 3 days since then? Put yourself in that time frame. What medications were used, and did you require a ventilator? Because that'll all tell you kind of the progression, how far and how severely impacted they were. And then some folks, after they've been intubated, they do have some throat hoarseness, they do have some swallowing issues. They may have some voice quality changes, and so you want to inquire, did anything happen post-ventilation? And are we expecting that to sort of recover as well? Outcome measures, important because this is how you prove that you're doing what you're supposed to be doing and the patient is getting better, right? So the GBS disability scale. For all of these diseases that we're going to talk about, there are disease-specific scales, outcome measures. Unless they've been proven not to be reliable and valid, start with those. Because it'll get you right, it'll get you to ask and get you to look at the questions that are appropriate for this person's recovery. So start with your GBS disability scale. Think about, if you're in an inpatient setting, they're probably doing the FIM. If you're in an outpatient setting, please don't do the FIM. Okay. It's embarrassing. The tug and the burp. How do they perform on that? You want to go on rehabmeasures.org or Physiopedia and find what's our expected if they have outcomes for patients specifically with Guillain-Barré. So in a Guillain-Barré patient, we would expect a change of X amount of points in the tug to be significant. And they'll give you that MDC or MCID. Okay, so you want to look and say, okay, how much is just good for you, good luck, that you increased or decreased 2 or 3 points, and how much of that is significant? Like we can say to the insurance company, they're actually getting better because they're having a pretty good therapeutic intervention, and not that they're sitting at home, just waiting. Okay, that's what the insurance company wants to know. Is this person going to get the same amount of better sitting at home without you, or are they getting return to function more rapidly because they're in a therapeutic program? All right, the 2 or 6 minute walk test, both are valid and reliable. It just depends on which, if the person doesn't have a lot of endurance, we're not pushing for a 6 minute walk test. Okay, let's go 2 minute walk test or a 1 minute walk test at that. The 10 meter walk test, a mini best or a high mat. All right, a lot of these will be clinic specific, depending on where you're at. The hospital or the outpatient setting or the rehab setting will use a specific battery of tests. So there may be others that you want to use. Obviously, range of motion you might want to throw in there, right? And some other of the sensory nerve tests. So these are your standardized outcome measures. And again, you can get the MCID and MDICs on rehabmeasures.org so you can compare your patient's progress to other patients' progress with that diagnosis. If it's not out there yet and you're working in a hospital that's seeing quite a few GBSs, then you can start to collect the data so you can develop and come up with the MBC and help the rest of the world. All right, interventions. So we're thinking about they have ascending weakness, right? That looks like paralysis. They may or may not be on a vent still. Even if they're on a vent, you're going to get them up and moving as best they can. They've hit nadir. So what are we going to do with them? We're going to work on respiration. Okay? Once they start sitting up, it may be a little bit easier to breathe because they've expanded their rib cage a little bit. It may be more difficult to breathe because now they're working against gravity. So figure out, so are they on the vent 24/7 or are they on the vent only at night? Can they come off the vent for a couple hours? What does that look like? Do you want to exercise them when they're off the vent or on the vent? Those are all things that you want to talk about with the medical team. What's their pain? Is there a way to control their pain? Can you use Annie O'Connor's stuff in the world, and Melissa's The World of Hurt, to if their pain is still bothersome and they're heavy on narcotics and they're doing all that and they're still having pain and they're anxious about a lot of stuff, but they're really anxious about this pain, can you help them kind of do a mind over matter and get control of their pain and understand their pain? Okay, maybe that's why you're sitting there. That's the best thing you can do is just do some patient education about the pain. Are they developing contractures or pressure sores? Are they not developing contractures or pressure sores? Okay, what does that look like, and what is being done to help prevent some of those contractures? Do they have positioning programs? Do they have a range of motion plan? Oftentimes the hospitals will do it every 2 hours. And again, that's a good thing for the families to be involved in. And when you're doing active exercise as you start, so they're kind of now, they've hit nadir, they're coming on back, we want to start with short periods of non-fatiguing exercise. That is going to depend a lot on everything. Their pre-morbid condition, okay? how long it was until they hit nadir, how long it's been since they've been really active. So those first couple days, you may just start with some very simple, what can they do? Can they do any active range of motion or active assist? So start gently. Sometimes just sitting up on the side of the bed wipes them out. So you do that, and that's it for the day. So what's happening there? Increase, and when we talk about increase, we're talking about reps and we're talking about weights and all of that. If the patient improves or has no deterioration within a week, so within that week, you're like, this week we're going to work on X, Y, and Z. You know, maybe we're going to work on just bed mobility and transfer. If at the end of the week we haven't seen a decrease in your abilities, then we're going to up that to maybe walking to the parallel bars or the next step. Okay? But you're not coming off the bat right away going, let's go to the parallel bars and see how you do standing. So you have to gradually increase these folks. They have to go back to bed if you're seeing a decrease in function or strength. They have to go back and rest. You cannot overwork these people. Absolutely cannot. So if you see a huge decline, back to bed, redo, we'll start over again. Really look for strengthening for functional purposes. These folks, they will do anything you ask them to do, but if you're asking them to just do dumbbell weights, could they be brushing their teeth with a weighted toothbrush? Could they be combing their hair with a little weight on the handle? Okay. So build it into function because they have very limited amount of energy when you're starting. So if you use all those energy chips just for strengthening some exercises or some TheraBand, and now they can't be functional. So these are the group that you really want to embed both and consider just while they're doing their functional activities, how to make that so they can strengthen while they're in that routine. Okay. And then finally, limit fatiguing exercises for 1 year. Again, these folks want to get up, out, and gone. And you've got to really slow them back because they will have these big setbacks. They'll push too far and then they're set back for a good amount of time. So within that first year, you want to be very careful about what they can tolerate and following up with them the next day. So if you're an outpatient, they're not in the hospital for a year. Right? So if they're seeing you an outpatient, these are the folks you want to call the next day, and now with text or have somebody text and be like, how you feeling, what can you do? And do a check-in after the appointment. Okay? Most of these folks will go to a day rehab, so you'll see them every day, and you can check in with them. You want to think about adaptive equipment and orthotics. This is a temporary fix, hopefully. But in the meantime, in that 2 years until they get back to where their previous level of function, they need to get around. So you're in that game of I need equipment, but probably not permanent equipment, but I do need equipment for a long term. Okay, so you want to think about the wheelchairs, you want to think about the cushions you're giving folks, because they are going to use them potentially for up to 2 years, maybe only 6 months. Okay, but you want to be mindful of, do they need splints? Do they need some adaptive equipment at home to help with hygiene and dressing and all of that? And then you just tell them, well, you can donate it back when you don't need it anymore. We'll pass it along. Okay. And the GBS Society they're a tight-knit group of folks. It's a club you don't necessarily want to belong to, but once you do, you're in for life. And they do a lot of equipment sharing. Because once you're done with it, what are you going to do with it? You know? And so, dressing aids and all those sorts of things, they just donate it around. But somebody else will be diagnosed with GBS. And then any psychosocial issues. Lots of folks have to move back home or move back, find caregivers. They may lose their jobs or, lose income. And so these are folks that may, depending on family circumstances, if you're the primary breadwinner for 6 people and you're out of commission for 2 years, that's 7 people that are really hungry over the next 7 years. So lots of working with the social worker and the social work group. What supports does the client need? What supports does the family need? And they may not need anything. They may be fine, they may be okay. But you always want to have somebody asking those questions of, are they getting the things they need for home? Okay. You don't want folks to be at risk for losing their home and losing all of their stuff while they're trying to recover as best you can. Okay. So that's GBS in a nutshell. Yes?
With NADR, is that something that the doctor diagnosis?
Yeah.
And then do they wait like 2 days until they let you see them or something, or they
No, you're seeing them all the way along. They've just determined this is as bad as they're gonna get. And so the next day, you're like, okay, it's the first day of the rest of your life, let's go.
is that just kind of based on experience from that?
No, the docs will look at their blood levels and all their immunoglobulin levels and all their testing. And they'll also look at our reports as far as muscle strength, they'll look at EMG. So they kind of they're tracking these things almost every day.
Do you track muscle strength every day then too?
Uh-huh.
How long are patients typically ventilated for? Does it just depend?
Just
on
depends. Depends on the person. Usually not more than a week typically, but again, it depends on the person. Okay, so they spend a good amount of time in ICU, and then they spend a little bit of time in inpatient, and they spend a whole lot of time like in inpatient rehab then. Because once they hit nadir, they'll wait for them, usually in ICU, to hit nadir, and then they'll move along. So they're waiting in ICU. Once they hit that and they're on the road to recovery, inpatient rehab is like, we're just gonna make sure you're stable. A little short stay there, and then they get folks into like an inpatient rehab program. And then they get them into a day program, and then they get them into an outpatient rehab. So folks like at Christ Hospital on the south side, Ingalls maybe, but you're looking for hospitals that have that progression. Okay? If you're hanging out at Little Company of Mary, you want folks move, like they'll transfer people out as soon as they figure out they have GBS. They'll move them down the line to Christ. But you want people at an institution, I don't know Silver Cross or Ingalls what they have, but you want somebody that has relationships with the whole spectrum. They go from ICU to inpatient rehab, to outpatient rehab day programs, to outpatient, looks pretty typical like an outpatient Athletico or ATI or ARC, whatever.
Right.
But the hospital may have every one of those components. The hospital wants to keep these people because they're like, okay, let's, you're good and you're a success story eventually. And so they like to keep them within the system. Does that make sense to folks? But you may spend a lot of time, you may go from Northwestern, now the relationship gravis. You know what I'm gonna, well, we're gonna quickly talk about myasthenia gravis. And basically myasthenia gravis is another sort of disease, degenerative disease process, but this is impacted by your systems. And the system, your immune system blocks the receptors in the muscles. They can't get the acetylcholine they need, so their muscles can't function. You know that acetylcholine is necessary for muscle contraction. And if that receptor is blocked, then you can't contract your muscle. Okay, so this is a little bit different mechanics. Folks don't necessarily recover from myasthenia gravis. You're seeing some very similar things to GBS and MS, is muscle weakness and fatigability on exertion. So they fatigue rapidly. Okay. Their proximal muscles are more affected than their distal muscles. So you're going to see shoulders and hips and trunk a little bit more, especially shoulders and hips, more so early on. GBS, remember, we see more distal is ascending. Asymmetrical ptosis is the eye droop. Okay, so their eyelid droops on one side, not the other. Their symptoms fluctuate wildly. So some days they're feeling pretty good, other days they're feeling very weak. That's hard for a PT. It's like a moving target, right? So you schedule somebody on Wednesday at 10, and they're like, I feel great today, great. Or I feel so horrible I can't get out of bed. So you have to be flexible in your scheduling with the folks with MG. All their other neural signs are normal. So they have good tendon reflexes, okay? They have good cranial nerve input. All right, so it's truly a muscle contraction issue. The ice pack test, okay, so this is a couple odd ways to test for MG. The ice pack test is you hold a glove or crushed ice over the eyelid for 2 minutes. Okay? If you do that and their eye suddenly works again, their eyelid is working again, you're like, oh, this could be a problem. You need to go see a neurologist. Okay, so somebody comes in with a droopy eye, put an ice pack over their head for 2 minutes, and then that droopy eye resolves itself. That's odd. Okay, that's just a little bit weird. The rest test is you place a cotton-filled glove over the eyelid, holding it closed for 2 minutes. And again, does that. So you're basically holding the eye closed for 2 minutes, all the way closed. And then it resolves. You might get a better result from the ice than the rest test, but again, that's odd. If somebody holds their eyes closed. And then finally, with the sleep test, you place the client in the dark room for 30 minutes. Hopefully they fall asleep. And when they come out of that dark room, again, it's all about that ptosis is that resolves itself. Okay. So the docs will do this, so the neurologists will do this. But again, you might see some of that going on. But that's the kind of quick and dirty testing for MG versus whether it's a cranial nerve injury or a brain tumor or anything else that's causing this droopy eyelid. Please ask if they've had a droopy eyelid for their entire life, because if they were born with it was a very big injury with forceps delivery. If they put the forceps right around here while you were being delivered as a baby, sometimes they paralyze the nerves that go to your eyelids, open your eyelids, right? If they've had it for their whole life, you've thrown an ice pack on their head for 2 minutes, probably isn't going to matter. So, and they may just get a little annoyed if you're pushing them into a room. All right. So interventions, and again, a lot of this is just education. This is a very medically controlled disease, but you're gonna see them in therapy, especially if they're connected with a hospital or a medical center. But one of the things you want to do is they need to plan their daily activities. Remember, they have limited energy. They have limited muscle contractions throughout the day. So they don't want to waste time up and down the stairs a lot, or back and forth in the house a lot, or in and out to the car a lot. Everything has to be very kind of put together and planned. Can you adapt the home? So can you get them a chairlift if they have stairs that they have to go up to their home? Can they rearrange the home so everything's on one level? So they move the bedroom down to the dining room or things like that. Can you get them adaptive equipment that they may need? Again, to help reduce energy cost. It's all about reducing the energy cost. Can they get adequate rest, and can they get help into the home? Can they get somebody to come in and care you? As simply as, do you have a cleaning lady or a cleaning guy or a cleaning service? Maybe somebody could come in and do a cleaning service so they didn't have to clean their house. Or come in and cook and clean and do all of those things. Okay. Really talking with folks on how they do energy conservation. Right? So you're really just training them. Think about their daily routine. How can they make that easier? What does that look like? How do you not carry a heavy bag? Maybe you have wheels, different things. Stick with cool temperatures. These folks in hot temperatures, they just melt, they fall apart. So you want things a little bit cool. This is important for your clinic because maybe, especially in the summertime, your clinic is cooler in the morning because the air's been running all night and there hasn't been anybody there working out and moving. Okay. Maybe your clinic is cooler in the afternoon because of the way the sun beats down on the windows and the fact that you actually don't let the air run all night long and kick it on when you come in the morning. Okay. But these folks need cool environments. They need to set their house. They'll be more comfortable in cool environments. All right. And then exercising, emotional stability. Get every one of these people into a support group. Like that's your second day of work. It's the first day you take the history and figure out where they're at. That night you go home and you find a support group for them all. Okay? They need to be in the clubhouse with their like people. Because they will get some nice emotional support and people that understand, that are more than just empathetic like we all are, but that actually understand and are living with the disease and have really nice little tricks that they may have come up with. Okay. Exercising submax in moderation. So if you have somebody with myasthenia gravis that was a heavy exercise person, like God forbid Mary Jones ever gets MG, right? We're going to have to sedate her. Okay. So you have to back these folks off so that they're not using their energy on their exercise. But it's a balance because maybe that's what keeps them sane. And so they have to come up with a different type of routine. Eliminating unnecessary daily tasks. You really have to take, a shower up on the third floor of your house twice a day. that really necessary, or could you shower every other day? Or can you combine some things? Do you really have to do your laundry every day? Okay? Or could you maybe do that once a week? Okay, so really delve, for these folks, you want to delve into their daily routine and find out what are they doing? If they're driving 2 hours commute every day, can they reduce that and do some work from home type of things? So again, MG, you're working, it's mostly medical, but you're working at trying to get them to adapt to a different lifestyle. Keep them as mobile as possible, increase in putting in technology. These are folks that you want to start infusing technology right away. Could you use that scooter? Could we get you a manual wheelchair, a lightweight manual wheelchair? Can you do a right to a power chair? Those sorts of things. All sorts of equipment for home. Some different outcome measures specifically for myasthenia gravis. And then you want to look at, besides just the MG-ADL, which will tell you, imply strength stuff, you want to do strength testing with these folks. Okay? You might want to do a 6-minute walk or a 2-minute walk or a 10-meter walk. You want to look at balance, because if they're not able to do their ankle and hip strategies, are they unstable as they're walking? Okay, so is it an endurance issue? Is it an instability issue and from fatigue? What's going on there? And then you want to document that, because over time, you're going to be able to tell, is the disease progressing rapidly or not? Oh, there's Liam. All right, so let's get into talk. Now, is anyone keeping this lecture? Okay, so that's going to ask you to turn off. For most therapists, MS is the worst diagnosis, because you get some cognitive shift, and folks are not, because they start reliably reporting for themselves, and they over time become unreliable reporters. And so there's this confusion that happens. It will drive you crazy as a therapist, because they're calling and complaining, they're doing a lot of stuff. So just know that there's a whole, potentially, not everyone with MS, but potentially there's a whole behavioral component that comes with MS, that if you start to see signs and symptoms of this, and typically you'll see it in the caregiver fatigue, because they walk in and they're like, they're just tired, that you want to start thinking about psychosocial work referrals and support groups for these guys too. But before we get to that, what is it? So it's an upper motor neuron. Okay, so different than GBS, this is an upper motor neuron. It's chronic, not acute, inflammatory demyelinating condition. So there's your two big things, GBS versus MS. Chronic versus acute, okay? CNS versus PNS, and it literally means many scars. I'm sure you guys have bumped into the pathology behind MS. Basically, it affects about 2.5 million people worldwide. So there's a whole lot of folks living with MS these days. And damage to the neurons in the central nervous system causes various sensory, motor, and cognitive symptoms, such as fatigue, pain, spasticity, memory impairment, and impairment of mobility. So you have the sensory component, and the motor component, and the pain component. So sometimes you have to pull out your world of hurt and become the pain management specialist, and then as well as the mobility specialist, okay? If you feel like you're not getting an accurate report from the person, I always put the caregiver behind them. And so if you had MS, I would go to Dave and be like, Dave, look at me. Okay, so I'm gonna ask you questions. You get the answer too. And so I'll ask you whatever questions. Are you walking at home? And you should. So you get feedback from the caregiver without the person realizing that that's what's going on. Okay? Because you want all the audience that comes with people with MS behind them when you're doing ministry, so you can poll the audience too, and that will tell you, because of this cognitive decline and perceptually, they think they're doing great, and the caregiver is like, well, after I carry them up the stairs and after we do this and we do that, you're doing spectacular. Okay, so you want to make sure that you're getting an accurate accounting of what's going on. Keep in mind that people with MS have been identified wellness, what I talked about a little bit before, but wellness is the priority for the MS group. We talk about them as a whole population of people. They want to be well. They want to maintain their wellness. So it's up to us to think about that, and it makes our treatment a little bit different. It also includes diet, exercise, and emotional wellness. So we got to make sure that we're doing the exercise part, but are they talking to a nutritionist that knows MS? Or a diet? Are they following a diet that's good for somebody with MS? Emotionally, are they supported? Is the family supported? So you want to think about all those things. Okay, it is race dependent, and women get it more than men. We'll talk about the race in a minute. Basically, you get hardened plaque-like areas throughout the CNS, primarily in the white matter and the optic nerve. Okay, so I have a friend who her only symptom of MS is it's in the optic nerve. Okay, and so if we golf in the summer, she has to golf in the morning because she can't get too hot. But she watches temperature, but her vision goes up and down. But that's the only signs and symptoms she has. Myelin damage is most likely mediated by the immune system, and there's some sort of viral trigger they're trying to get their hands around of what. We can ask Debbie if they've started to identify that yet, but it was kind of the big unknown for a while. Symptoms may develop pretty quickly, but they'll start to complain about visual changes. They'll start to complain about fatigue, walking, bowel and bladder issues, all right? Cognitive issues and tremoring. So there's going to be this onset of, again, they think they had the flu, they think they had a virus of some nature, but all of a sudden they have an onset of a myriad of, not quite as fast as GBS, but enough that they've noticed that there's something wrong, that they're getting tired a lot quicker. So they're going to go to their doctor and complain about those sorts of things. Their vision is blurry. They're having a hard time with nighttime urination. Like they have to get up and go frequently. Okay, so they'll do a whole workup on those symptoms. So here are the plaques that you can see in the brain, and now the diagnosis is again through EMG and through MRIs. Here's what the myelin looks like. I always say that this looks like a road in a well-paved road, maybe a nice road that's less traveled, and this looks like my trip down Ogden Avenue when I'm going into the city. Okay. And so, but you see this scarring and you see this breaking up of the myelin, and so then those signals can't go through. And what happens is that breaking up is then replaced by scar tissue. Well, scar tissue doesn't conduct well, the nerve, right? The nerve impulses doesn't conduct well. All right. But one and done is not the rule of the game. So you have to show up at your doctor twice and complain of these symptoms twice. Okay, otherwise you just had some wacky virus that you recovered from. And they have to, on MRI, show 2 lesions. So you have to have 2 lesions somewhere in your brain, somewhere in your lung, your upper motor neuron system. All right. There's several different ways and different types of MS that you can have. I'll quickly rattle these off, but you can have, most folks have relapsing remitting MS. Okay, so it comes and it goes, But each time it comes on, when it goes, you're left with a little bit of progressive damage. Okay, so you never quite get back to that prior level of function. So that's a problem for our folks with relapsing and remitting MS. 85%, basically it's characterized by exacerbations that can last months, maybe days, maybe months, and are typically followed by improved function. So they'll have this exasperation, then they'll get better, so they don't quite get back to that prior level of function, okay? But they do improve, okay? So it's just sort of waiting it out. What does the person do to wait it out while the flare is occurring? During remission, function can return close to that relapse level, but most frequently it does not. Attacks normally occur with a frequency of 1 to 2 times a year. And you want to ask folks what's their pattern. Because if you see an increasing of that, it may be a progression of the disease. And then approximately 90% of people with relapsing and remitting MS transition to that secondary progressive MS after about 20 years. Okay? So you're going to see a progression. So you go from RRMS to a secondary, but in the meantime, primary progressive MS is less common. Only about 10% of folks get that, And from disease onset, progression results in a gradual worsening without any relapse. So they just get worse and worse and worse and worse, and there's no timeout. All right, so the most folks we're going to see is relapsing and remitting, but you may see a progressive, the secondary progressive, which just keeps going, and there's no remitting, or there's no relapsing.
Secondary or primary?
I'm sorry, primary progressive. So primary progressive is it just gets worse. It doesn't ever let up. Secondary progressive, relapses decrease in frequency over time. And so that time out, whereas your relapsing remitting is like you have an onset once or twice a year, becomes more frequent when we get to the secondary progressive. So they're more frequently having issues. So what do we do about all of that? So here's kind of in a graphic display, if you don't like words so much. Here's kind of how it goes. So if you have relapsing remitting, you have a little increase in disability, then you get better, you have an increase in disability, then you get better. But you see, you never quite get down to your best, okay? And our secondary progressive, a similar pattern, but eventually you just start sort of looking like a primary progressive, where these times of feeling better get less and less. There's longer times in between when you're in remission, there's longer and longer times in between. Primary progressive, there isn't any remission. Once it starts, it just keeps going. And then progressive relapsing MS, again, similar in the fact that there's less remission than there is relapse. And as you go out over time, you just get worse and worse. Okay? Yep.
Did you mention how you can know which one that the patient has, or do you just
The doc and the medical team will determine this, but a lot of it is based on history and presentation. So what do we do with these folks? So here's a diagnosis, clinical. So a lot of it's medical. They're going to come to you, right, with a good medical history. You're going to redo your neurological exam. You're going to do your all your cranial nerves. You're going to do your sensory. You're going to do your motor. All right. You are not probably going to do vision and auditory evoked potentials, but you're going to look for that and say, is there a problem with your vision? Is there a problem with your hearing? Some of these folks early on, depending on where the lesions are, you want to do some of your functional vision testing and that eye team. Okay, so you can do that until it gets to a place where you can't do that and they need visual support. All right. Women are more likely than men. There's a young adult onset, so again, right about your age. Most of you did not walk in the room with MS, so as you're feeling fatigued and a little cognitively drained, probably not developing MS. MRIs can diagnose MS earlier, and right now it's kind of a matter of protocol. You show up at your physician. If your physician is not horribly passive, they'll usually send you for an MRI right away. Okay. It is not contagious, like you can't catch it, so if somebody sneezes, you're not going to get MS. But there is a familial component, so you will see MS in families. Okay, so there is a component to it, but it doesn't necessarily mean that if you have a family member with MS, you're going to get it too. All right. In the tropical climates, it is not where if you live close to the equator, your risk of getting MS and developing MS is less than if you live closer to the poles. Okay? So, when we talk about racial and ethnic diversity, folks that live close to the equator tend to be darker skinned, right? So that's the racial component. And if you've grown up though, so let's say you live close to the equator, your first 10 to 12 years of life, you're still at risk. And then you move to Antarctica, you still might get it. I mean, you won't, I'm sorry, the reverse of it is you're safe. But if you lived in Antarctica or in Norway or Finland for the first 10 to 12 years of life, and then you decide you hate cold weather, and so you move to Belize, you may get it. All right, so folks who tend to live in cold environments, you see more incidents of MS. that make sense to folks? Except for one population. Folks that live in a cold environment, but they don't have a great occurrence of MS. Who would that be? Anyone want to take a guess?
Eskimos.
Huh? Caroline?
Iceland. I don't know.
Close. Keep going.
Greenland?
No.
Maybe it's
The
Eskimos.
Eskimos. Why?
They dark skinned.
Why do you think the Eskimos don't get MS? Even though they live in a perfect MS environment, right?
High fat diet.
Sorry, say?
I didn't say it.
What is it?
High fat diet.
Yeah, it's all about the diet. They eat a lot of that good organic blubber fat, like not McDonald's fat. And so it's all about their diet, and what they're eating is neuroprotective, to use terms from earlier. And so it prevents MS so we don't see a lot of Eskimos getting MS, even though they live in a cold environment. Okay, so that's the one population you won't see it. So when they're recruiting you for travel PT to go work in Anchorage, safe bet if you don't like people with MS. All right.
We just think about it.
So it could be, we're not quite sure the cause. We'll ask Debbie about that again. We've talked about this a lot, but typically, here's your myriad of things, systems that can be impacted. Vision, balance and coordination, strength, they kind of, they all sort of go together. Sensation, speech and swallowing, bladder control, sexuality, and cognitive functions. All right, so that makes it a little bit different than your myasthenia gravis or your Guillain-Barré as far as the impact of the bladder control and cognitive functioning. Okay. So be aware of that. If somebody with MS comes in and says they're not having bowel and bladder problems, but they have an odor about them that indicates otherwise, you may want to do some digging on that as well and make sure that they're wearing protective undergarments now that are available that help with that social piece of reducing odor. Folks are losing bowel and bladder control.
Does the person's cognitive function kind of go along with their physical function?
Who is that?
Sorry.
That's pretty funny. That's the person's cognitive function?
Yeah, is that like associated with their physical function? So if they're like getting better, will their cognition get better, and then when they relapse with their cognition, then kind of go down with?
From the best of my knowledge, it's the cognition is kind of a general decline, and it doesn't quite mirror the motor performance that you're saying. So and the cognitive performance is very gradual, and it's more like a reality check. It's because they're reporting they're doing fine, and they're great, and the caregiver at home is like, oh, they fall 8 times a day, and I gotta pick them up here, and I gotta be there, and they don't want to recognize the fact that they're declining. So they stop doing their checkbook, but now you guys live in a world of technology, so when's the last time you hand balanced your checkbook?
No.
You even have checked? Like I think I have Crystal shake 3 checks, and it's like, what is this for? It's all about me. So some of that cognitive decline is masked by technology. When you can send somebody a text, they don't have to sit down and write a handwritten letter and address it and put the stamp in the right place and do all of that. So you can adapt and so the person has a kind of a skewed sense of how much assistance they really need. But the caregivers can fill you in on that. Or you can ask very pertinent questions like, when's the last time you cooked at home and followed a recipe versus pulled out a, healthy gourmet frozen dinner and heated it up in the microwave. There's a little bit of a cognitive functioning there. Right? And that's where we really want to use technology to keep people as functional as they can. Does it really matter that folks didn't make scratch spaghetti sauce last night or they opened a bottle of Perrier? It's personal preference. All right, outcome measures again, specific for MS, modified fatigue impact scale. These are nice because they give you reliability and validity data for people with MS. So you can compare your patient to the population of MS, and are they functioning pretty okay, above average, or below average within their group? Okay, so they may be functioning below average if we compare them to the normal general population. But compared to the population of MS, they might be doing pretty okay. Right, so we want to be well. I'll show you the expanded disability status scale. This daily activity diary is really important, especially if you're working in a clinic situation where you only see folks annually. So you ask them the month before they come to visit, will they track their activities and send that to you? And now they have, again, with a lot of the home programs and computerized stuff, you can just have them track it on their phone and send it to you very easily. So here's the EDSS, and it looks specifically at and asks specific questions on no disability, minimal signs in one of the functional skills, all the way down through disability severe enough to impair your full daily activity, okay? And so unable to take more than a few steps, essentially restricted to bed, confined to bed, and totally dependent. Down to 10, of course, you get points for that. So death due to MS is a 10. So you go literally from 1 to 10, and as you show impairments, your score goes up. Okay, this is just the general oversight of the EDSS. Vision, I'm gonna click through these to get to balance and coordination. You should all know about. You're gonna see these in Guillain-Barré. You're gonna see them in myasthenia gravis. Motor, you're going to see, obviously, MS affects your legs more frequently than your arms. People report more issue with mobility. Think about Janet that came. Ambulation affected. All right, cognitive. So stuff we were doing with Janet, whether you realize it or not, was recall. What did you do yesterday? Does that make sense? Is that level of activity? Concentration. Do some puzzles and abstract reasoning. Help with these folks. Sudoku, crossword puzzles, any of those things. So while they're in the waiting room, you have them doing that sort of stuff just for cognitive reasons. All right, pharmacology, we don't get invested in too much. Or we get invested, but we don't get involved with it. If we're thinking about the WHO model and the ICF, this is how it lies out for specifically for folks with MS. And this is what Debbie's going to address this afternoon, is how does strength, balance, spasticity, memory, and coordination impact your ability to carry out your daily routine, which impacts your ability to participate in your life. This is familiar to all of you. And personal factors that will impact that. If you have transportation available to you readily, if you have an accessible home available to you readily, if you have a caregiver that happens to live with you, your ability to participate and be active may be much different than someone who lives in a townhouse. It was a great idea, but the first floor is 2 rooms, and then there's like 2 rooms on every level, and the bedrooms and the laundry are on the top floor. That's really a horrible situation for somebody with MS. So how does, what are their beliefs? Are they kind of a get up and go sort of person, or are they a Eeyore? Oh, I have MS, life, horrible. That person versus Tigger, right? Who's like, put it, I don't care what you do to me, but life is good. Is going to have some different outcomes. All right, your examination is truly what you guys know, right? There's nothing in this list of things that should be unfamiliar with you right now, but you really want to look at endurance, and then if you have the luxury of working with an exercise physiologist, have them do some cardiovascular and respiratory. If you see that they're getting a lot of colds or they're getting a lot of congestion, refer them, because they're losing some respiratory issues, okay? But you want to look at all of these things, work on all of these things, be aware of what folks have to know whether they can, if they have trouble swallowing or not, what they should be eating and what they shouldn't be eating. Rice is a killer, okay? If you have trouble swallowing, rice is bad news for you. Even if it's sticky rice, which you're like, this should be pretty good because it all goes down in a lump, gets to your throat and decides to break up. If your throat can't manage that, then you have trouble. Okay, so you want to be asking about what are they eating, what thickness are they drinking if they're children.
If they are having difficulty with drinking, isn't it recommended that they should have more like thick liquids?
Yeah.
Versus like
Well, it's really recommended they go to a speech therapist first and get a swallow study. But yeah, and there's thickener you can put in.
I have people drink that like Jello, like, and they're like, I just want water instead of like Jello.
Yeah, but if they have water, what happens is they can't manage, and the water ends up in their lungs, and they have pneumonia. So if it's thicker, it stays on the right side of the throat and goes down the esophagus into their stomach. And sometimes people cheat anyway, but you don't want to cheat on your time. All right, look at, for our PT interventions, we're thinking about fatigue. That's just coaching, right? And that's just making sure that they're not running all over the place. Balance and coordination. Watch vestibular hypofunction. So do a lot of your VOR and your vestibular training, okay? Sensory-wise, these are folks that if they can't feel the whatever's in their shoe, then they're going to get a wound down their foot. So treat them a little bit like a diabetic. Check their feet every day. Check to make sure everything's okay. Ambulation, we live in a variable, seasonal, every day is a different season around here. So do folks have ability to walk outside when it's slick? Today's a good day to be walking outside. Tomorrow, allegedly, is going to be miserable. So do they have a walker that they use, or do they have a strategy that they use when it's slick outside, or when the weather has changed? Exercise training, it's important that, and Debbie's going to talk a lot about exercise training this afternoon, but I did grab in her article, the one by Bacchus particularly, there is a nice chart that talks about barriers to exercise. And again, some of those are things like in your clinic, things you can change. Okay, so look at that. There's two nice charts. One is the barriers and one's what you do about it. I tried to cut and paste that for you today and was having a miserable time at home. But the fit equation is really a nice way to keep in mind how to dose exercise for folks with MS. Okay, what's their frequency, what's the intensity, the type, and the time and the duration. And they remember fit. So keep them to, listen, we're going to do daily exercise or every other day exercise. Keeping in mind that walking sometimes is a great exercise. So if you can get out and walk around the block, can you walk to get your mail? Okay, some folks, their mail gets delivered right to their door. Other folks, they actually have to walk to a mailbox. That's a great, that's your job. You get to get the mail every day. If you have to walk out of your house, down some steps, and go get the mail out of the mailbox. Okay. Intensity-wise, are we asking them to go sub-max or maximal exercise? These are folks that we really don't want to exercise at a max level. But they should do some gentle exercising almost every day. So a nice walking program, a swimming program. If the heat, depending on the temperature of the water, you have to watch the temperature of the water, okay? Bicycling activity, treadmill, and whatever they got. And then the time and duration. If they're feeling stronger in the morning, can they exercise there, but you don't want to wear yourself out. Okay? So you might have to work with them on sort of an exercise plan and an exercise recipe. All right, does that make sense to folks? So be mindful when you're dosing people's exercise that you dose it appropriately. And then coming back to that EDSS level, here's just when you're talking about training. So that's taking that 0 to 10 scale, that 1 to 10, 1 you're doing great, 10 you're dead. 10 doesn't even make it because you don't have to exercise when you're dead. Once you're dead, you're alleviated of all exercise requirements, right? But if they're at a 0 and here, no fatigue, no reaction to heat or cold, then full exertion, okay? Probably no extreme sports, but for the most part, how many people in the general population are doing extreme sports anyway, right? So get them moving though. They can be at the gym, they can be working out. As they start to get more impaired, start to think about just targeting where their deficits are and having them exercise and practice those routines to keep those better. But maybe they can use a stationary bike instead of an outdoor bike, okay? Because you can control that a little bit better. When they're down to severe, you're really looking at movement preservation. So when we're thinking about Janet, we're not sending Janet to the gym to do super amounts of exercise. We just want to keep her where she's at, moving so she can grab her cup, drive her chair with a joystick, transfer as best she can. So you're really looking at just keeping strength. So we have movement preservation, lots of stretching. They're going to start to get contracted, right? Janet probably falls right here between 6 and 7. And then 8 and 9, when they're in bed bedridden, if you're seeing that person, it's all about skin protection and joint protection. So passive range of motion, good mattresses, no bed sores, no pneumonia, those sorts of things. Okay, does that make sense to folks? So for all of these diagnoses, and the ones we'll talk about next week too, it's your job to dose the exercise appropriately for the pathology that's going on. Right?
People with MS, when they're around that extent level, are they still able to be at home or do they need a special?
It probably depends on the home, right? I mean, if you're living alone in a place where there's little visitors, and you can't get out of bed anymore, it's hard to keep your just natural physiology. So those folks may go to a residential, probably like a nursing home or an assisted living type of thing. But many folks with MS will stay at home as long as they can. It's just a matter of how much assistance they're able to be there, and if that assistance is available to them. Folks with cash can pay, you know. But again, you're paying a pretty significant amount of money to get somebody to